Stenting. It's a joint session between EBC and SCAI Bifurcation Club. I'm pleased to co-chair this session with Marie-Claude Morice and Goran Stankovic, who are with us from internet. And Dr. Jolanta Siller is with us as a panelist. And from SCAI, we have George Dangas as a master in New York City, and a nice combination of US speakers. George, you are connected with us?
We're all connected over here from the Cardiovascular Research Foundation Manhattan offices with faculty from Cornell and NYU.
Thank you very much. I think for the sake of time, we'll go directly to the first talk, which is from Dr. Garcia-Garcia about the feasibility of a porcine AV shunt model to assess acute thrombogenicity in bifurcation stenting.
My name is Hector Garcia. I am professor of medicine at Georgetown University, and I am also the director of invasive imaging coronary at MedStar Washington Hospital Center. It is my pleasure to present to you the feasibility of a porcine AV shunt model to assess acute thrombogenicity in bifurcation stenting using optical coherence tomography. Thank you, dear Mr. Chairman of the European Bifurcation Club, for this kind invitation. What we did is shown here at the upper left. So we have used a big model from where we have taken the blood of the carotid and connected to these tubes. And the tube was connected to our silicone bifurcation model, as shown here in the picture. And then the blood would exit at the other end and return to the jugular vein of the porcine model. We would keep this going on for 1 hour, and thereafter we would check the optical coherence tomography for the presence of thrombus. These are the models we have used. We have used a decay crash model. You can see here the microscopic view, and we also use a culotte model. The panels in the middle are simply the fluoroscopic images as shown here. What we have done is 2 pullbacks, is 1 pullback coming from the distal main branch, going into the bifurcation, and then moving into the proximal branch of the section of the main branch of the bifurcation. Then a second pullback coming from the side branch, and then imaging these portions. The ones that we have eventually analyzed are shown in this color, and it can be here seen at the bottom of this slide. This is one of the examples that I like to discuss with you. Is a decay crash example. So this is the microscopic view of the accumulation of thrombus in the side branch right after the bifurcation, as we can see here. So this is zoom out, and at the bottom left, you see the thrombus attached to the struts, and also here on the proximal main branch, although in the microscopic view is not obvious. We did a 3-dimensional reconstruction. These yellow arrows point at the accumulation of thrombi, and you see here as well on this other longitudinal view at the lower bottom of this image. This is presenting the areas of the thrombus that we have measured. So in green on the left-hand side, the decay crash models. On the right-hand side, the culotte stenting models. And as you can see here, we observe actually thrombi in all models, but the bare metal, the top 2 models, accumulated more thrombus than the drug-eluting stent model, as shown here at the bottom. So the accumulation of thrombus was present mostly in the bifurcation segment of all these segments. And as you can see that the bifurcation was affected here in the decay crash in the bare metal stent, but also in the culotte stenting and in the drug-eluting stent model and in the drug-eluting stent culotte stenting model. But the size and the amount, of course, was more in the bare metal stent altogether. And also altogether, I would say it was mostly accumulated in the culotte stenting than in the decay crash stenting. So we have extended our observations, and this past year, what we have done is to evaluate two different drug-eluting stent platforms. We keep our bare metal stent as control. We use an abluminal polymer sirolimus eluting stent, and we also have this durable polymer everolimus eluting stent. So again, at the top row, what we have is our decay crash model. At the bottom, we have our culotte model. And in green circles, we are showing you the portions of the bifurcation with no thrombus, and in red, those areas of the bifurcations with thrombus. So as you can see already, we see more red circles at the bottom row, which is the culotte model, in all of the different stent platforms. We see many less in the decay crash arm. Of course, it's obvious for you as well to see that the decay crash thrombosis occur mostly in the side branch, portions of the model, and in the decay crash remains mostly at the bifurcation, but also in the side branch, but the rest of the models do have thrombi right at the bifurcation. At the top, what we have here is kind of the conclusion of this new analysis that has been submitted, is culotte stenting is associated with more thrombogenicity, mostly at the proximal main branch in the durable everolimus eluting stent, and also at the side branch in the bare metal stenting, and also at the bifurcation of all the other models. So the decay crash demonstrated mostly thrombogenicity at the side branch of the bare metal stent and the abluminal polymer sirolimus eluting stent. So this is leading me to my discussion slide. So the number of thrombi with culotte stenting was more compared to that of the decay crash, 13 frames versus 17 frames. And these findings might explain why in the decay crash 3, we see a superior performance of this decay crash model than the culotte stenting model. In the decay crash stenting, the durable polymers show no thrombus, and the bare metal and the abluminal sirolimus stent had some thrombus, mostly in the side branch of the model. This might also be consistent with the findings in the decay crash, where our durable polymer everolimus stent show significant reduction in TLF at 3 years. So this brings me to the single conclusion statement that I have here. I think this model is showing us for a second time some hypothesis generating findings regarding the distinct thrombogenicity patterns of these bifurcation stenting techniques with different stent platforms, in this case, durable polymer and abluminal polymer platforms. Thank you for your attention.
Oh, thank you. Very, very interesting and nice lecture. I go to Dr. Dangas in New York. Do you have comments to make on this presentation from Dr. Garcia?
First of all, let me thank European Bifurcation Club for this invitation to organize the hub from New York. And let's introduce our panelists here. Dr. Dmitri Feldman.
Hi, how are you? Nice to be here.
From Cornell. And Dr. Binita Shah is with you from NYU. And you can see. Speak a little bit more so it can pick up.
It's nice to be here with you all today. Thank you so much for having us.
Okay, great. We're all getting used to the automatic cameras. And we have Dr. Juan Granada, who's going to make the first comment from New York. He's at the CRF Skirball Center. Juan, thank you for joining us. And clearly this is a basic science-oriented subject, animal model in some ways by Hector. Please offer us some comments regarding this.
First of all, thank you for the kind invitation. It's actually great to be here with all of you. I am very well aware of this work, and And it was greatly done by this group, and I understand the methodology. One of the things that one has to take into consideration is there is a significant variation in technique. When people do these procedures in actually humans, even though there is a standardization, the human anatomy is somewhat actually different when it comes down to the results that actually you get in these benchtop models. But the nice thing about these benchtop models and animal models is that you can standardize the way you do it to be able to get more homogeneous results. This has been a chronic discussion that we've had, including with Greg Stone and Professor Royce in the past, about the potential thrombogenicity or difference in thrombogenicity of different polymers. And the data, continues to show that fluoropolymers, have these kind of like a Teflon effect that repels, thrombus formation. And it's been actually shown not only on the bench, but actually also in vivo animal models done with OCT. The question is, if these differences in microscopic thrombus accumulation really translate into clinical practice. And this is where, clinical studies are really important to answer this type of questions. But if you actually look at the basic level, fluoropolymers that actually are used not only on stents, but actually also other products do seem to offer an advantage in terms of anti-thrombogenic effect compared to other apparently more benign bioresorbable polymers in different studies done by actually different people.
Dr. Shah has done a lot of work in inflammation. Could we use this model to assess maybe inflammation as well, not just a thrombus, or maybe both? Dr. Shah, what do you have to say?
Yeah, that would be very interesting to see if there's any macrophage accumulation around the different sites, to see if there's any, that would potentially correlate with future ISR. Of course, ISR is quite complicated, and there are multiple factors that go into it, not just inflammation and not just thrombosity. We've got the plaque underneath, the degree of calcium. So it is quite complex. I do wonder, I have a question for the presenter. Have you looked at this model using various, different lumen sizes? So for smaller branches versus larger branches, and if so, did you notice any difference there?
Thank you, Dr. Shah. Very interesting question. No, we have not done it. And this is particularly for one reason. We, as Juan mentioned it, we of course were hypothesizing whether this model would ever work to pick up this thrombogenicity, and we show again 2 times that it does. But now the plan, the follow-up studies, let's say, go in the variations not only in the size of the side branch, but also in the type of bifurcation anatomy. So different angles, different size of the diameters of the vessels. So we want to continue to explore it, but it is an important consideration. For the inflammation part, I think, Juan, I don't know if you can complement this, but we could eventually extract these stents and send it over to the lab and have some analysis for the accumulation of other type of cells.
Yeah, and as a matter of fact, when at the beginning of the bioresorbable polymer, work, we did some work looking for inflammation and trying to understand the differences between durable polymers and bioresorbable polymers. And one thing that is interesting is, at the end, the result is the same in terms of inflammation. But at the beginning, you pay a little bit of a higher price because the absorption of the polymer elicits a little bit more inflammation than the durable polymer. But then at the end, there is a catch-up effect because the drug goes out, and then the durable polymer starts accumulating a little bit more of cells. So it's actually fascinating to see, the dynamics of vascular healing with these 2 type of technological approaches.
This was terrific. Thank you very much. We are moving back to Bernard to see if there are any comments in the room.
One question from the floor, yes?
Excellent work. Just a question about, did you perform any computational fluid dynamics to see if there was any correlation? I
am laughing because you read my mind. Yeah, that work is coming. Thank you. It is coming. Definitely, we are doing it. Yes.
Okay.
Marco Zimarino, who is listening very attentively,
Yes.
had done a lot of work with us in the antithrombotics. And what do you think about any short comment, perhaps?
I think that that's a fantastic basis, because that's a true basis for understanding what means complexity in terms of platelet activation. And it would be really interesting to develop a model for testing a different scenario in terms coming from the fluid dynamics into translating into the platelet activation to understand what is the substrate for what we fear. Stent thrombosis now is no more a great fear, but it's still something we have to care of.
Maybe just one comment to Hector. Great job, but I believe you are now, according to choose Dicky Crush and standard culotte, you are not up to date, because even in our center we don't use any more standard culotte. So every cases are Dicky culotte. And why you see the problems? Because in standard culotte there was no enough post-dilatation job done. And that's a difference to Dicky Crush.
Yeah, that's a very good point. And I think the other technique that is the elephant in the room is provisional stenting. I think we should have that as a control as well. Thank you for encouraging to continue our work. Hopefully next year we'll report the next set of results.
Yeah.
And the next talk is from George Dangas.
Hello from New York, and my pleasure to be part of EBC 2021 with this very interesting presentation on abbreviated short DAPT, followed by ticagrelor monotherapy, insights from global leaders and the Twilight-Complex studies, of which you can see my related disclosures pertaining to other studies. For the most part, the Twilight study was funded by AstraZeneca through a grant at the Mount Sinai Medical Center. And this is what the Twilight-Complex study first of all did. Let's all remember that the Twilight study included patients with at least one clinical and one high-risk and geographic criterion. And out of those patients, those who had a successful 3-month period of aspirin ticagrelor ended up being randomized into placebo plus ticagrelor, that means monotherapy, for a year versus continuing ticagrelor plus aspirin. So it was a double-blind study. And out of all those patients, we had many thousands, nearly 7,000 randomized. Almost over 2,500 had a complex PCI at the index procedure. And it included bifurcations with 2 stents at the index procedure as one of the criteria. And you can see here the rest of the criteria as published earlier by Justino and Colombo. 3 vessels treated, 3 lesions treated, many stents, long stents, left main PCI, CTO, atherectomy, and graft. And in general, we're going to follow the bottom left part of this graphic that you can see here. Out of the 7,111 patients, 2,342 had complex PCI performed, and subsequently we're going to compare ticagrelor plus placebo versus ticagrelor plus aspirin in this presentation. First of all, let's talk how many of those were bifurcation. 250 were bifurcation with 2 stents, over 10%. The most common high-risk feature was the stent length longer than 60 millimeters, and you can see the distribution of the rest of the characteristics. Overall, the bleeding was much more favorable, as expected, with a monotherapy as compared to ticagrelor plus aspirin continuation. With respect to the ischemic endpoint, that most importantly, that's what really bothers and interests people. They really want to know that, sure, bleeding can be reduced, but are you as good as you can be as far as a MACE? And you can see that not only MACE itself on the left side, but also any other individual endpoint was comparing very favorably. In the darker bar, the placebo group, ticagrelor monotherapy, as compared to ticagrelor plus aspirin on the lighter color bar. And if we want to go specifically
to PCI characteristics. Bifurcation with 2 stents right in the middle. You can see that at the top graph. No issues at all, right in the middle of the, I would say, pretty similarity. And overall, all the characteristics, each one of them, none of them was an outlier indicating more of a harm than anything when aspirin was dropped. And even if we add the characteristics, on top of one, we had a second, we had a third one, you can see on the bottom right side that the characteristics were very, very favorable comparing as well. When we go now to global leaders, there's some similarities in these 2 studies. Global leaders much bigger. They were all the way out to 24 months. In the experimental strategy, they only used 1 month of aspirin and followed by nothing. It was an open label study. In the reference treatment, according to the risk profile of the patient, either ticagrelor or clopidogrel for 12 months and definitely aspirin for 24 months. This was in general global leaders. Going down to the characteristics, we have about 475 patients with bifurcation with over 2 stents, and the more you can see in the middle, about 3%. And overall, the most common characteristic of complexity was the multivessel PCI, or more than 3 stents. This is the flavor of all the results, and you can see that regardless of the characteristics found, we can see that in general, all the endpoints trended favorably for the green bar, which is the experimental strategy with the abbreviated aspirin, versus the orange bar, which is the classic extended aspirin, extended PY12 combination. I want to extend these observations by adding another study that has just been published, a very comprehensive, over 24,000 patient meta-analysis of many studies, DACAP, GLASSI, which is the part of global leaders that had full adjudication, Smart Choice, Long DAPT, TICO, as well as Twilight. And you can see now, we not only in a binary, in a percentage point, but you can see that over the spread of time, the bleeding seems to be mitigated with an increasing rate over time. So you save a lot more bleeding as the time, months, and years pass. On the other hand, what happens with MACE? I would say not a lot. Not a lot happens with MACE. And you can see here that essentially over the months and years, the 2 curves look very similar. The abbreviated DAPT with a short aspirin duration, just 1 month, versus the P12 monotherapy continuation, faring very, very, very safe. Again, you can go down some similar analysis in this very large study. The primary outcome, the all-cause mortality, the myocardial infarction, the stroke, and the faring very similar between the groups, and the bleeding very much better. And in fact, with a newer antiplatelet agents, the more potent ones rather than clopidogrel, even the mortality seems to be trending somewhat more favorably for the abbreviated monotherapy part. If we're going to examine more specifically the complex lesion on the left main PCI, we don't have such an analysis yet for the bifurcation, but you can get the flavor. Very, very, very similar overall. Again, great safety profile. So in my take-home message, we know that DAPT is thought to reduce subsequent ischemic events. We also know that the substantial proportion of patients high bleeding risk, and switching to monotherapy after an initial short DAPT duration does reduce bleeding. At the same time, we no longer believe that aspirin alone is the only strategy. A P2Y12 monotherapy has emerged as a bleeding saving strategy without apparent drawback regarding a possible higher ischemic risk, even in complex PCI, and twice in the clearly including bifurcation with 2 stents, a high-risk bifurcation, I would say, over 200 patients in Twilight, over 400 patients in global leaders. Thank you very much for your attention. Now I look forward to the rest of EBC 2021.
So the next talk is from Dr. Kim.
Dear Chairman, great thanks for invitation to EBC 2021st meeting. I'm Hyo-soo Kim from SNU, Seoul National University Hospital. The title of my presentation is Long DAPT period after two stenting bifurcation in COBIS III registry. There are still remaining issues regarding bifurcation PCI. Which one is better, one versus two stenting? When two stenting is required, such as side branch is big enough to supply a large mass of myocardium, which antiplatelet regimen is better? Which technique is the best? To answer this question, about 5 years ago, we reported results of Granada-DS registry. That is 10 years of clinical excellence. We completed 3 years follow-up results for this over 13,000 patients with 18,000 lesions treated with contemporary DS from SNU Hospital and 55 centers in South Korea. Among more than 13,000 patients, about 40% of patients were bifurcation lesion. Among them, 13% were left main bifurcation patients treated with either two stent, 80%, versus one stent technique, 20%. The results is shown here. 3-year TLF rate is 20% after two stent versus 11% after one stent. Thus, two stent was worse than one stent in terms of 3-year TLF. But when we analyze two different groups with shorter DAPT, less than 1 year, longer DAPT, more than 1 year, the line was totally different. In shorter DAPT group, 3 years TLF rate after two stent was about 37%, while one stent still 11%. But in population with longer DAPT, more than 1 year, 3 years TLF rate even after two stent technique is 15%, very close to 11% after one stent technique. Here's high TLF rate after two stent technique, such as 40%, can be reduced more than half by prolonged DAPT. In landmark analysis at 1 year, here, divergence really happened under the coverage of monotherapy. We analyzed independent predictors of target lesion failure in Granada-DS registry. Here, after two stent technique, short DAPT is really a strong, poor prognostic factor to determine target lesion failure. But at that registry, we cannot get answers which technique is the best one among several different two-stent techniques. To get answer from this question, we analyze COBIS III registry. Which technique is the best one? How important DAPT duration is? We enrolled more than 2,600 patients having bifurcation lesion to meet such kind of criteria from this period. Among them, 70%, 454 patients received two stenting technique, mainly side branch first or main vessel first minority. The stent technique, the crush technique is the dominant, more than 50%. T-stent technique, about 30%. Culotte kissing V stent, less than 10%. We completed 4.5 years follow-up. Here is the angiographic profiles among different two-stent technique. The sequence, main vessel first and side branch first. Which factor determines the sequence? Here, side branch stenosis grade is very important factor. If it is tightly stenosed, physician prefer side branch first. If the main vessel lesion is long, physician prefers main vessel stenting first. How about for different techniques? The most important predictor factor to determine culotte stenting is side branch size. Here's 5 years clinical outcome. Totally, 5-year stent thrombosis is just 1.3%, even after two stent technique. It's a very wonderful result. Target lesion failure, just 11%, even after two stent technique. There's no difference between main vessel first versus side branch first or for different techniques. Here is the incidence curve of target lesion failure up to 5 years. around 10%. Systemic versus provisional to stent, no difference. Here is low side of recurrence. About half of the recurrence happens at the side branch. Remaining half was distributed in main vessel, proximal, and distal. How about the instance curve of 5-year TLF among 4 different techniques? A little bit higher in T-stent, less than 10% in 3 different techniques, but there is no statistical significance. Here's once again low side of restenosis. About half of the recurrence happened at the side branch. Remaining half is distributed through proximal or distal main vessels. Interesting findings, Q-load or kissing restenting structure is similar, same between 2 vessels, thus recurrence is shared by 2 vessels. Here's independent predictors of TLF after 2-stent technique for bifurcation rates in total population, Propensco matched population, and IPTW analysis population consistent. Left main and short DAPT is a risk factor. When we increase DAPT duration per 1 month, we can protect the TLF. We analyzed the distribution of DAPT duration in 46 patients with recurrence and 408 patients without recurrence. We can see the left skew deviation in recurrence and right deviation in no recurrence. Point of intersection is 2.5 years. Thus we checked 5-year TLF rate among DAPT duration less than 2.5 years and patients with a duration more than 2.5 years. Huge difference. Such a 2.5 years also emerged in a recent analysis in other Korean population. Here, this analysis includes more than 1,100 patients with left main coronal lesion. Once again, long DAPT was better, and MACE rate declined as DAPT duration increased at least up to 2.5 years. To conclude my answers to remaining issues, when 2-stent technique is required, long DAPT is required, necessary. Regarding technique, it may be chosen depending on the anatomy of bifurcation as well as your experience. Thank you very much for your attention.
Thank you, Dr. Kim. The next talk is from Dr. D'Ascenzo, adverse effects at 3 months versus 12 months after the DAPT cessation in patients treated with thin stents with ULM or on coronary bifurcation.
Dear Chairman, thanks for the invitation to the EBC 221 Congress. I'm Dr. D'Ascenzo from Turin, and the title of my presentation is the adverse events of dual antiplatelet therapy for patients treated with stents on unprotected left main or coronary bifurcations. And recent evidence have shown that the risk of MI in patients treated with different kind of length of DAPT does not differ. For example, in this recent network meta-analysis published in JACT, de-escalation did not increase risk of subsequent MI or revascularization of death, and of course, reduce risk of minor bleeding. And this is something very important. But from the other point of view, we all know that in this randomized controlled trial, patients with high-risk PCI are not represented or underrepresented. For example, in the ONIS-1 trial, only 12% of these patients were treated with a bifurcation with 2 stents, and of course, these patients were a high risk of recurrent events, and only 5% of these patients were treated with left main PCI. Similarly, in the global leaders, we have something more regarding sample size. About 10% of the patients were treated on coronary bifurcation. Again, we don't know the kind of strategy used, that is, we don't know if these patients were treated with provisional stenting or with stenting with 2-stent PCI, and we don't know even the technique of 2-stent PCI. And of course, these patients have a higher risk of recurrent MI and of any subsequent revascularization and also stent thrombosis, both definite and probable. One of the few trials reporting some data about complex PCI is this non-pre-specified analysis of the Stop DAPT trial. The authors tried to put together all the complex PCI, that is about 17%, including free vessel PCI, more than 3 lesions treated, a long length of stents, and also bifurcation with 2 stent strategies, which were clearly underrepresented, and putting all of them together, a longer length of DAPT, 12 months of DAPT, reduced risk of MI and thrombosis, that is risk of NACE, compared to 1 month DAPT in complex PCI. And this trend was not present in a patient with non-complex PCI. But of course, as you may clearly depicted from the Klappenmeyer analysis curves, these patients were underrepresented, and so we're speaking about a few patients and really a little number of events. In the Grand Death Registry, which enrolled 700 PCI performed on unprotected left main, DAPT interruption before 12 months represented a marker of risk for target lesion failure and from thrombotic event recurrent events in the vessel and on the other vessel. So the take-home message from this registry was that a long DAPT, even longer than 12 months in these patients, may be of interest. The COBIS II registry, including 2,082 patients performed in Korea, demonstrated after a propensity matched analysis that DAPT longer than 12 months reduced risk of death of MI, and these results was confirmed also in all subgroup analysis. Interesting, the only limitation of this registry was that most of the stents used were first generation deaths, and so the question which arose was if the results of second generation death, which was neutral about the benefit of longer DAPT, was derived from the low sample size or from the protective effect of second generation of thin or ultra thin stents. So we tried to analyze all this data together. That is, we included the data from the COBIS and from the RAIN registry, and we created the Bifurcation registry. That is, we put together our patients to reach about 5,000 patients treated with PCI on bifurcation or unprotected left main, and we try to analyze the potential benefit of DAPT of 6 from 12 months versus DAPT shorter than 6 months and DAPT longer than 12 months. We performed 2 subgroup analyses, that is patients with acute coronary syndromes and patients with chronic coronary syndromes. In patients with acute coronary syndrome, the benefit of DAPT between 6 and 12 months was not present when compared with DAPT shorter than 6 months, but also after multivariate analysis, DAPT longer than 12 months reduced risk of major adverse cardiac events compared to DAPT between 6 and 12 months. And these results disappear, this benefit disappear in patients treated with PCI because of chronic syndrome, in which the trend was not significant both when comparing DAPT between 6 and 12 months versus DAPT shorter than 6 months, or when comparing DAPT longer than 12 months versus DAPT of 6 and 12 months. And in a multivariate analysis performed with different techniques, the benefit of DAPT longer than 12 months was confirmed from death, from MACE, and from subsequent MI in acute coronary syndromes, but was not confirmed in chronic coronary syndrome. And again, we performed a subgroup analysis in these patients, and the benefit of DAPT longer than 12 months was present irrespectively of strategies performed for bifurcation, that is, choosing strategies, provisional stenting, both for patients treated with left main and non-left main, and also independently from the DAPT score. But the benefit disappeared in chronic coronary syndrome. So the conclusion is that we know that patients with bifurcation are underrepresented in randomized controlled trial. In observational registries, even after adjustment for confounders are Long DAPT seen to exert protection from HES patients, but it does not exert protection from chronic coronary syndromes. So if the bleeding risk is low or acceptable, a longer DAM seems to be reasonable for HES patients treated with PCI on bifurcations. Thanks again for the invitation to this meeting.
Thank you, Dr. D'Ascenzo. And the last talk before discussion will be from Dr. Angiolillo, DAPT de-escalation option after bifurcation lesion with a two-stenting strategy with DS.
Hello, my name is Dominic Angiolillo, and today I'll be speaking to you about the DAPT de-escalation, and I've also introduced the concept of escalation options after bifurcation lesion with two-stent techniques. These are my disclosures. So when we speak about the de-escalation, we're speaking about switching from prasugrel or ticagrelor to clopidogrel as a strategy to reduce the long-term risk of bleeding without any trade-off in ischemic events, while escalation is the switching from clopidogrel to prasugrel or ticagrelor as a strategy to reduce thrombotic complications without a trade-off in bleeding. And what we do know is that this strategy works, and more specifically, when we're speaking about a guided escalation or guided de-escalation approach. And when we speak about guiding, this is by the use of either platelet function or genetic testing. As you can see, as mentioned before, the concept of escalation, you reduce ischemic events and thrombotic complications without a trade-off in bleeding. And while the de-escalation, it's a reduction in bleeding without a trade-off in thrombotic complications. Now, it is important to keep in mind that when we're speaking about bifurcation with two-stent techniques, this is by definition a setting of high thrombotic risk as recognized by the ESC guidelines. So when we're speaking about de-escalation, this by definition implies that a patient is already on a potent P2Y12 inhibitor, such as in the setting of an acute coronary syndrome. And therefore, the recommendation in general is not to de-escalate unless you have a good reason. And this could be due to drug access or due to non-bleeding side effects, for example, dyspnea if the patient's on ticagrelor. But for the most part, we also can consider prasugrel in some of these patients if there isn't a contraindication. So truly the reason to de-escalate in these patients, if you really have an individual who's also at high risk for bleeding complication, an HBR patient. And the reason why we are concerned is very simple. We know that if you de-escalate, you're going to a drug which is clopidogrel, characterized by a broad degree of inter-individual variability. And therefore, you have a significant number of individuals who remain at risk for thrombotic complications. So the general rule is do not escalate soon after PCI, and beware of the fact that you have an increase of platelet reactivity due to a number of reasons. One, you're switching to a less potent P2Y12 inhibitor with clopidogrel. You have the prothrombotic environment post-PCI, particularly for the setting of an acute coronary syndrome. And let's not forget that when you switch, particularly if you're going from ticagrelor to clopidogrel, there is a risk of drug-drug interactions. And we have plenty of data to support this. This is one of the many registries, such as the SCOPE registry, showing that when you switch early, particularly in the early post-PCI phase, and this is, again, it's not specific to bifurcation, this is specific to a patient with acute coronary syndrome, there is an increase in thrombotic complications. So definitely we would not want to put ourselves in this position, particularly if we have a patient with recently treated with two stents for bifurcation in the setting of acute coronary syndrome. The second rule that we should consider is that consider waiting at least 30 days before de-escalating. And ideally, de-escalation should occur when guided by platelet function or genetic testing, as I already mentioned before. Now, each one of these tests have pros and cons. One of the things to keep in mind that if you're considering de-escalating to clopidogrel and you want to understand the response, platelet function testing may not be the best option because the patient actually needs to be on the drug to define response. And so sometimes it may be a little bit too late to understand whether it's worthwhile to be on clopidogrel or not if you're just relying on platelet function testing. And this is the advantage of genetic testing because genes don't change. And the only issue is that genetic testing is not always a direct measure of response. But we can improve the accuracy by the way which we use genetic testing and predict response by using a score. This is the ABCD gene score, which integrates genetic information together with clinical information, A, B, C, and D. In other words, age, body mass index, chronic kidney disease, and diabetes, each one with an integral scoring system. And if the score is above 10, you have a very high likelihood of being a poor responder to clopidogrel. This is something that we do use in our practice now that we have rapid genetic testing assays that give you a result within 1 hour. Now, an alternative of the de-escalation, although it's really not the true concept of de-escalation, I'm going from a more potent to a less potent P212 inhibitor, but yes, considering reduction in antithrombotic agents, is that of stopping aspirin. And you can see here, there's an analysis from the Twilight-Complex, the Twilight study, which is the Twilight-Complex analysis, which did include as one of the anatomical factors bifurcation with 2 stent techniques. And what we learned from this analysis published by George Dangas in JACC is that there is consistency with the overall trial findings. So significant reduction in the bleeding without any trade-off in ischemic events. When it comes to escalation, this implies that a patient is on clopidogrel, such as a patient with stable CAD, and it's a reasonable approach if a patient is not at high bleeding risk, if you're concerned about poor clopidogrel response. In my practice, I consider prasugrel over ticagrelor if there are no contraindications, simply because prasugrel is a true PCI drug. It's a once daily regimen. There is no dyspnea, and there are no concerns about drug interactions when switching back to clopidogrel if needed at a certain point. So again, it's not because there is any specific pharmacodynamic difference. I just think it is a more user-friendly approach to consider prasugrel if there aren't any contraindications. And last but not least, when switching, whether this is a de-escalation or an escalation, always switch to the alternative agent using a loading dose administration. And you probably want to do that 12 to 24 hours after the last maintenance dose of the drug. If you're doing a de-escalation strategy, instead of you're doing an escalation strategy, it really doesn't matter. You can do it even right away because there aren't any interactions when you escalate to a more potent P212 inhibitor. Thank you very much for your attention.
Thank you very much for these excellent talks. I imagine excellent discussion with these talks. Who has a question for our speakers?
Yeah, I will try mostly to make a common line among all these really high-level talks. I try to be the chat moderator. So because we heard something between George Dangas and Professor Kim that could be different. In one way towards treating towards longer duration, another way towards shorter duration. But I think I spoke with George several times in order to prepare our paper. And I think that Twilight really opened a new scenario. We are coming from an era in which we were afraid about thrombosis. Coming through the beginning, when George gave me the results of Twilight-Complex, I always thank because I read them before publication. I was afraid about perhaps a similar results, but they are pointing towards a direction in which shorter DAPT ameliorates even all survival. And this comes very clearly also from the patient-level meta-analysis that has been recently published by Matula. I think that the care, this is a technical and pharmacological mix-up. The care about doing PCI with imaging, with less strats, it can allow shorter duration, and this can translate into a long-term benefit in terms of survival. I would try to make this commentary, but I'm open to question too, because I think that we are going into an era in which there is more imaging in complex cases in double stenting, while provisional allows us to, because I think that we saw the results from the Lee population, that's the largest population protected left main. They were all angiographic driven or angiographic guided procedures. So when you use complex cases and you make the most with imaging, you can support shorter DAPT, and shorter DAPT pay off a better survival in the long term, in my opinion.
Dr. Angiolillo, want to comment?
Yes, thank you for the invite. So I would like to expand on what Marco you just said, and I fully agree. But I also want to make sure that the take-home message is that whatever type of short DAPT, whether de-escalation, whatever it is, that whatever the agent you are on, the agent must work. So it's very, very different, the Twilight-Complex study, because you have a background of ticagrelor, and we know from pharmacodynamic data on a background of ticagrelor or prasugrel that adding aspirin does not add much. And I think we had a very good lesson that we learned from the Stop DAPT ACS2 study that clearly showed that when you drop aspirin and stay on clopidogrel after an ACS, you're going to have an increased risk of ischemic recurrences. So in a population, such as an Asian population, at lower risk for thrombotic complications. So I always like to be mindful when we're thinking about the shorter DAPT or de-escalating, that the agent that you have on board is effective. It could be ticagrelor prasugrel. You can sleep at night, you're fine. But if you're going to clopidogrel monotherapy, I would urge caution. And we've implemented in our practice the ABCD gene score. It's very simple. We have it in our electronic medical records. And this is something that we also consider, for example, in our patients with AFib undergoing PCI, where we also drop aspirin right away, and we keep them on an oral anticoagulant. So I think it's the same concept. You want effective inhibition with whatever antiplatelet you're on in these high thrombotic risk patients.
Can I make a quick comment as well? So I think the presentations were outstanding, and the controversy continues where we have data for post-bifurcation PCI for both short or shorter DAPT as well as longer DAPT. We've seen data, that benefited short DAPT. We've seen data that benefited longer DAPT. And I think it's very important to recognize that we are discussing a very heterogeneous population, both in terms of clinical milieu, which is extremely important. A patient who's coming in with ACS, if you're going to do a complex bifurcation with presence of thrombus perhaps in those lesions, is very different from a bifurcation in a stable CAD patient. A diabetic versus non-diabetic patients. All those factors will play both with respect to platelet aggregation as well as a technique that you will be using, right? A provisional technique versus a crush, let's say a collage. So there's that concept. But I think it's important to recognize that when deciding short DAPT versus long DAPT, number one, what we've learned from Plato and Triton and the trial of stronger antiplatelet agents versus clopidogrel is a shorter duration of DAPT with stronger antiplatelet agent is important. And so Twilight hit that, where at least for the first 3 months, you have to be on dual antiplatelet therapy with a stronger antiplatelet agent. And that's that's a very thoughtful design and a thoughtful rationale to doing that. After 3 months, depending on the milieu, clinically, as well as what kind of bifurcation technique, we can start talking about a de-escalation, so to speak, either dropping aspirin or coming down in terms of the strength of P2Y12. But to Dominic's point, if you are going to come down and take out aspirin out of the equation, you better make sure that you are on an agent that works. You take out of the equation, the 30% of clopidogrel non-responders. You have to be thoughtful about that approach and take into account, what kind of technique you've used, how good of a result you got, how big the stents were, et cetera, et cetera. So I think, the controversy is not solved in terms of is shorter DAPT better versus longer DAPT, but we do need a very thoughtful approach when we decide on whether we're going to use short DAPT and what agents we should be using.
Excellent remarks. We have a question or comment from Patrick Serrais in the room.
One question and one comment. The question is, what is the proportion of upper GI bleeding? That's the question. And the comment is, we should not forget that already 1 decade ago, Armstrong tested 6 agonists on prasugrel versus aspirin. And basically, aspirin was not adding anything to the 6 tests. I mean, prasugrel was doing the tricks. So the question is, what is the next frontier? Eliminating the aspirin, is that's what we are going to do? I'm impressed by the fact that Takeshi Kimura in Japan has already randomized 1,600 patients, CCS and ACS, without aspirin, and apparently the DSMB in Japan has not stopped the study. And on top of that, the dose of prasugrel given to that population, Asian population, is only 3.75 milligram, which is almost 3 times less than what we use in the Caucasian population. And then you have Adnan Kastrati, which is planning his trial with 9,600 patients without aspirin. We are running the ASSET Japan, which is also without aspirin, and so far we crossed the finger, but it's good. So that's the question that I have for the panel there. First the question, because I don't really know exactly the upper GI bleeding,
So maybe I will try to address Professor Serrais' comment and question. So yes, indeed, as I had alluded to before, Armstrong and Warner have conducted very elegant pharmacodynamic analysis and using an array of agonists in the presence of potent P2Y12 lactate, which was either ticagrelor or the active metabolite of prasugrel. Aspirin has very little to offer. Now, for the skeptical of these pharmacodynamic data, one would say, well, the markers that were used are not always reflective of aspirin-specific effects. And the truth is, when you're looking at aspirin effects, unless you're looking at arachidonic acid-induced aggregation or thromboxane levels, you're really not going to see much. But the benefit of these assays, and this is all my response to those who don't believe in it, is that they are looking at the big picture, okay, at the global thrombogenicity. We now have some more specific techniques to look at it, which were not available at the time. I'm a fan of the TTAS, which is an assay from Japan, to look into this. Regards to the incidence of GI bleeding, again, without going into too much of the details, we know from RCTs around 70% of the bleeding is upper GI, more or less, and this is clearly attributed to aspirin-induced gastrointestinal toxicity. Aspirin-induced gastrointestinal toxicity is due to many factors. not only the impaired hemostasis, but the inability to generate productive prostaglandins, and 3, the direct effect of aspirin on the GI mucosa. So you have a trifecta here that leads to the bleeding, and which is the reason why there are a number of manufacturers looking at newer or formulations of aspirin that don't attack the gastric mucosa, but attack in a different section. But that's a completely different story. But don't be fooled that the enteric coating that we use in everyday clinical practice in the United States and in Europe protects from this, because it does not. It actually impairs absorption without protecting from a GI effect. So I'm very excited to hear about the data coming from our colleagues in Japan and the results and the outcomes of the DSMB, and it's extremely encouraging. Hopefully I address your question, Patrick.
I wonder if what we've seen before as part of the aspirin effects is also a part of an anti-inflammatory block from the aspirin. Could we, take care of the thrombotic part by the most potent agent, and maybe we have a chance to employ some kind of a non-specific or specific, we'll see later, with other agents, anti-inflammatory therapies, and that combination may be more fruitful and maybe better agents than aspirin. Dr. Shah has done some work in that. Perhaps we can go down that pathway. Maybe that's a hidden issue from aspirin, that everybody thinks thrombosis. Maybe there's something else.
Yeah, I mean, inflammation can certainly play a role in these long-term events, cardiovascular events that we're seeing in our patients. And Ladoco 2 sort of strengthened all the other data that we've seen in the past, where colchicine is associated with lower risk of MI rates in patients who are at high risk of having myocardial infarctions. But the other thing to bring into play is when we're thinking of patients in non-cardiac surgery, right? So when we have adverse outcomes in the setting of non-cardiac surgery, we also think of a component of inflammation here. And that makes things pretty tricky, because most surgeons won't operate on a P2Y12 inhibitor unless they're quite experienced in that area. And so then if you are thinking of de-escalating or relying solely on a P2Y12 inhibitor, if that unexpected non-cardiac surgery comes up within the first year, sort of changing that strategy and trying to figure out what antiplatelet agent the patient should be on and how that transition should occur perioperatively becomes very complex as well. So it does become intriguing if inflammation does truly play a significant role in the adverse events that we see perioperatively in non-cardiac surgery, whether or not the addition of some sort of anti-inflammatory agent in that transition setting would be helpful. These are all just questions, food for thought, and definitely ripe for exploration.
Thank you for this excellent discussion. We have to move on to next talk, and there will be another discussion there. Next talk is done by Roxana Mehran, and the title is Optimal Duration of Antiplatelet Therapy Following Left Main and Coronary Bifurcation PCI.
Dear Chairman, thank you very much for having me giving this presentation at the EBC 2021 European Bifurcation Club meeting. It is my honor to be here, and I'm presenting on optimal duration of antiplatelet therapy following left main and coronary bifurcation PCI. So I want to just go straight to the matter of why we worry about dual antiplatelet therapies in large bifurcation and left main, and it's all about stent thrombosis and stent-related complications. We obviously have been very, very careful about selecting the duration of dual antiplatelet therapy for these patients because of the fact that stent thrombosis, both at the level of the lesion as well as the device type, it's all about the bifurcations being an important predictor and residual dissections and those important things. And I think it's important to think about stent thrombosis, especially when we're talking about left main or proximal LAD. And you know that in the Prodigy trial, the longer duration of DAPT was more protective in reducing stent thrombosis when there was a left main or an LAD lesion. And left main is obviously always thought about as that patient with a higher burden of atherosclerosis. So when we make clinical decisions for DAPT duration after PCI, there are many, many things we take into consideration. And what I have here is the DAPT score that has been shown to be very interestingly applied, even though I believe the DAPT score is for patients who've tolerated a year of the antiplatelet therapies. But when we look at the DAPT score, there's no role for left main in the DAPT score. These stents are usually large in diameter. And as you know, in the DAPT score, there is a +1 score assigned to the stent diameter, less than 3 millimeters, but that's not really what we're seeing in left mains. Usually they're larger than that. So prolonging DAPT seems to be better for smaller vessels, but we often think about in bifurcation lesions when there's a lot of metal in the carina, especially where we worry about stent thrombosis. And I think obviously that catastrophic event is what we worry about. And in fact, if you look at the Paris registry in left main PCI, and the patterns and associations really do have an important impact when we're seeing DAPT cessation, where if it is disrupted, there is a very important association with 2-year outcome, especially in left main PCI. In Excel, we did have some data. Excel was for left main PCI. The DAPT duration was evaluated. And if you actually look at DAPT duration in Excel, you're seeing the unadjusted values showing that discontinuation of DAPT seems to be okay in death MI stroke, ischemia-driven revascularization, et cetera. And it looks like this is not randomized to the duration of DAPT, but again, even if you adjust to remain on DAPT after 1 year, there was only a non-significant trend towards harm with extended DAPT. All-cause mortality was very, very similar. So I don't think we have really clear answers in left main and bifurcation because we've never really randomized in that patient group. Let's talk a little bit about the bleeding risk in these patients in left main PCI. And I think that's another area. I mean, when we think about bleeding, it's really what's going on after the hospitalizations. And we worry about these patients having high bleeding risk. And in some of the data that we have presented now from our hospital outcomes, you're seeing that these patients also have a lot of bleeding. We saw 55% of the patients meeting the ARC criteria who come in with left main PCI. It shows you that these are high-risk patients, and we're seeing that 1 year post-discharge, these patients who are at high bleeding risk actually do end up with a lot of bleeding. In ideal left main, which was an 800-patient study, where the Synergy stent was married to only 4 months of DAPT versus Xience with 12 months of DAPT, with a clinical follow-up followed in these patients, we didn't really see a differential benefit. In fact, there was a little bit higher trend of all-cause death MI and ischemia-driven revascularization in Synergy plus 4 months of DAPT instead of 12 months. And I think you saw that really it was about the fact that bleeding is what matters, and still higher bleeding in the Synergy 4 versus 12 months. We saw that as well. Left main and bifurcation, there are a bunch of new generation DES subgroups that have been evaluated in host Biolamus Korea, excellent prime, excellent prospective cohort, and all together with new generation, over 5,000 patients and 700 left main bifurcation. And in that grand DES registry, DAPT duration determines outcome after 2 stent, but not 1 stent strategy, showing again that interruption would be more catastrophic when you have 2 stents as opposed to 1 stent. So it kind of comes back again for us to think about complexity of the lesion and DAPT duration. If you have a 2-stent implantation, longer stents or chronic total occlusions, we're calling those more complex lesions and probably seeing a better benefit in prolonging DAPT in those patients. And in the pooled analysis that Gennaro Giustino did with 6 randomized trials, 3 to 6 versus 12 months, you see that there was the lesion complexity is what really drove the benefit for prolonging DAPT. And in fact, you could see that beyond 12 months, reduction of MI, stent thrombosis with extended duration of DAPT was similar between those in complex and non-complex. That was in the DAPT study, but in this other study where he looked at the pooled analysis of 6 randomized trials, it was about the PCI complexity. And to me, this makes a lot of sense. If we look at high bleeding risk patients using the precise DAPT score and complexity, the work by Costa and Falgemigli are tremendously important. And even with complex disease, high bleeding risk patients should not be getting longer duration of DAPT. And I think the other important thing is that in the Onyx 1 study where we looked at the 1-month DAPT and complex disease, we did not find an issue at all with DAPT duration. And you can see with the Onyx patients, complex and non-complex patients did similarly. So I think in conclusion, the stent protective aspect of DAPT following PCI has always been the priority. And I think what you really want to do is make sure that we protect the stent-related events with DAPT for a period of time and still come back to the risk of the patient in evaluating whether they should get extended DAPT or shortened duration of DAPT, and that has to do with bleeding and ischemic risk. I think it's really, really important to not to marry as soon as you have someone with bifurcation and left main disease to give them 12 months of DAPT. We've seen that in high bleeding risk patients, that's important to actually reduce the duration. So I believe we need a lot more data in these patients, and I'm looking to the European Bifurcation Club to actually come up with a great trial design where we can look at duration of DAPT in these complex patients with 1 or 2 stents. Thank you so much for your attention.
Thank you for the talk. Marie-Claude, Morice, you want to comment on this talk or the previous talk?
No, thank you, Philippe. It was, as usual, wonderful talk. And I think we had a lot of discussion about, it seems that it's clear now from that when we are speaking of long or short DAPT, we are moving that it's not the same as if the single therapy is aspirin and another agent, and that's the reality. Because we saw talks that seems to be completely going in other directions, saying that shorter is better, but shorter is better when the single antiplatelet agent is a potent one, and not that's it's again what was said by Dr. Tim and D'Ascenzo, where the DAPT and SAPT were the classical one, clopidogrel and aspirin. And if Dr. D'Ascenzo is still with us, I wanted to ask him, because it was very interesting to see that both in Prof. Kim talk and in his talk, which was the meta-analysis, there was an advantage, at least for the acute patient, to have a very prolonged DAPT over 1 year. But we never saw anything in both talk about the bleedings. So do we have that? But I'm not sure, Dr.
I'm not sure he's still connected.
No, he's connected, but not doesn't seem. Yeah, because for me the question. Speaking of length of DAPT, we have it's not only length; it's also the intensity, for sure, and SAPT in particular.
So there seems to be
yeah, Goran wants to comment.
Goran, yes, Goran.
Yeah, thank you very much, Marie-Claude. Actually, it's more question for Marco Zimarino and maybe George Dangas, because in our consensus document on antithrombotic treatment in bifurcation PCI, we discussed the role, and algorithm contains the role of imaging and should help us determine maybe the length of DAPT based on use of imaging and probably optimization of the procedural result. So I think we should maybe discuss if we have some evidence that was a main driver for this inclusion. Marco.
Yeah, we discussed a lot about this because there is no direct evidence. It's always and always a translation of a consensus expert agreement about the impact, because we see that in the last year we have better results even in complex cases. Twilight, I think it was 30% imaging. George, perhaps I'm wrong, something like that for more complex cases, Twilight-Complex. And it's a kind of continuum towards, we came out with a kind of recommendation, meaning when you're not, where you are in a complex double stenting, imaging can play the role of shortening DAPT. So it means if you are treating an high bleeding risk patient, better doing imaging because you can be more assured in reducing DAPT. That can be. There is a small report, I think, if I remember, in an American journal 3-4 years ago, in which imaging was performed in before non-cardiac surgery patient or neoplastic patients in order to reduce DAPT, and it was in order to be assured about the endothelialization of the struts. But they are always derived, not direct evidence, but derived suggestions. George.
Thank you so much.
Thank you, Marco. Had some internet issues with the voice, but yes, indeed, you're going to be sure, as Dominic said before, when you're dropping an agent and go to de-escalation, you're going to be sure that this is a strong agent or that there are no issues of the agent not working. Same way, if you want to go to a pathway that you're going to favor less antithrombotics, you're going to be sure that the stent job is as good as possible, particularly in the complex bifurcation with double stents. On the other hand, I must say that always imaging comes out good, makes sense. And, in our lab is used about, as you said, less than is about 25%. I don't know if you go around other centers in New York, let's say, Dr. Feldman, what is the utilization of imaging over at Cornell? How do you feel about that?
Yeah, we're in the same boat. The utilization is somewhere between 20 to 30%. But I think to your point is when you use imaging in terms of the optimization of your bifurcation stenting and deciding what the DAPT should be, you're asking a question perhaps, what is the minimum, what is the shortest duration of DAPT that you can tolerate? And that's a good and important question. But the other question that we always ask and that we're debating is, what is the ideal duration of DAPT for patient post-PCI? And that discussion is very complicated because it's not just the bifurcation, it's not just the technique, it's not just the patient milieu, but just like the DAPT study showed, the longer you go, more than 12 months, you are preventing not only stent-related events, but almost 50% of non-stent related events. So you're getting into this discussion of, yes, the bleeding will be higher, as we've seen, we know that, but you're also preventing ischemic events, some of which are stent related, but a lot of them, as you go longer and longer, are no longer stent related. And so that balance is a much more difficult discussion. So, but yes, to answer your point is, if you want to answer the question, what's the shortest DAPT duration, I think imaging is helpful.
Thank you for these excellent comments. I'm sorry, but time has gone. I would like to give the opportunity to Jolanta, Siller, and Matula to comment or ask a question.
Thank you so much. So my question and the comment is to the panelists is whether you believe that we should move into some precision medicine concept for very short DAPT duration, following by monotherapy with P2Y12 receptor inhibitors. Because for ticagrelor and prasugrel, we know there also might be some patients who do not respond properly, like 3 to 5%, as compared to clopidogrel monotherapy. So do you believe that, at least for bifurcation lesions, do we have data on this, or do we need some clinical trials on this? How safe it is to de-escalate from the dual therapy to a monotherapy for those patients who have, especially both, who have a high bleeding risk and high ischemic risk because of the bifurcation?
Maybe since I spoke about this, I will answer. The short answer is yes. I think we're going more and more towards a precision medicine-based approach, and whether this is using pharmacogenetics, pharmacodynamics, or both, or integrated with clinical variables, as I've shown. I think anything that's considered a high-risk setting, we should be more open-minded to this. And I think the data, particularly when we look at the aggregate of data coming from high-level meta-analysis, do support this. I think it's a change in mindset. And again, in my presentation and in my comment before, I just urge a lot of caution when de-escalating. Don't de-escalate too early. If you're gonna de-escalate, always use testing. And if you're gonna stop aspirin, make sure that you have effective P2Y12 inhibition on board. And these are all measures, in my opinion, of precision medicine.
Thank you so much. Thank you for this excellent session. Fascinating discussion. I would like to thank all the speakers, the panel, and my co-chairman, Bernard Chevalier.